Good morning, everybody. Welcome to our June Grand Rounds, and we're going to have a special visitor today, Dr. Arnoczky, and I'm going to have Albert G. Do that introduction. First, we'll start off with, we have quite a few kudos to go over. And after I finish this, if the coffee has arrived, we will take a 2 to 3 minute break and fill our cups and come back in. Apparently, the first batch ended up on the floor. And the first kudo is for Anthony Yee, and it's from the staff at Children's Hospital. And we're fortunate enough to have so many of these today that I'm going to really abbreviate them. And this starts out by saying Dr. Yee was amazing at explaining steps to a patient and really took the time to walk the patient through everything in a developmentally appropriate manner. The second one is for Mario Taylor, and it is from Harborview, from a nurse manager. Mario has been a pleasure to work with. All of the nurses and hospital assistants really like him. He has a great bedside manner, and he shows a great deal of respect towards patients, family members, and staff. I don't know if Mario is here or if Anthony is here, but I suspect they're watching remotely, so thank you. And the next one is for a bunch of our residents also at Harborview, and it's for Alan Swenson, Claudia Chrisman-Scaler, Matt Barron, and Eric Magnuson. And it's from Steve Mitchell, who's the medical director of the ED. And it says, the presence of the ortho chiefs was very appreciated in helping the R2 and the ED during a particularly busy and challenging weekend. Please pass along our thanks and gratitude for their willingness to help. It made an enormous difference having an extra set of capable and experienced hands to handle the volume of patients requiring orthopedic care. Thank you, Alan, Claudia, Matt, and Eric. And the last one is also from Harborview, and it's for Dr. Swenson. I would like to acknowledge Dr. Alan Swenson from Orthopaedics for his outstanding patient care and communication skills. I have interacted with him many times in the last few weeks, and in every interaction, he is professional and respectful. In dealing with patients, he is proactive, compassionate, and takes his time and listens. And that's also certainly my experience in working with Alan. One more announcement, and we'll check on the coffee after this. So at Grand Rounds, we honor faculty who have hit certain anniversaries of being in the department. And this morning, we have a plaque for Antoinette Lindbergh. Come on up. This is a little late, so it's actually 5.5 years now, but congratulations. It's great to have you. And you have to put your pin on now.
Okay.
So.
Thank you.
Do we have coffee? So why don't we just take a short break, everybody grab a cup, and we'll start after that.
All right, so I guess everybody's pretty much back, so why don't we get started. Thank you, everybody, again, for coming to Grand Rounds. We're very excited to have our guest speaker here, and I have some notes because Dr. Arnoczky's CV is quite long, so to try to compress it down into a quick little intro takes a second. So I have the distinct pleasure of introducing Dr. Stephen Arnoczky for Grand Rounds today. He comes to us from Michigan State University, where he's part of the College of Veterinary Medicine, and he's the Wade Brinker Endowed Professor of Veterinary Surgery. Dr. Arnoczky did his undergraduate at the Ohio State University, as well as his veterinary training, and then was basically from there went to New York City and started working with some of the mentors that I had there, or have there at the Hospital for Special Surgery, and kind of with Cornell University and their relationship with HSS. He was the started as an assistant professor of comparative orthopedics and surgery at Cornell University, and that was in 1979. And if you want to know, Steve, I was born in 1979. So that's when he started his career after completing his training in veterinary medicine and doing his residency. And he quickly rose to associate and then full professor at Cornell, and then was there for about 13 years, it looks like, and then went to Michigan State, was recruited there, had a great deal given to him, and it seems like he's been pretty happy there because he's been there for about 25 years now. His awards are too numerous to list here. He's won the O'Donoghue Award twice. He's won the Cabot Award, both from the American Orthopaedic Society for Sports Medicine. He's a Neer Award winner from the American Shoulder and Elbow Society. He's also won a Kappa Delta Award, and he's a member of the Sports Medicine Hall of Fame from the AOSSM as well. And his research has covered just about every area of orthopedics, basic science, both in the human and animal realms. He studied virtually every human and animal joint, be it the shoulder, hand, hip, or knee, ankle, foot. In the animal, I guess, stifle, pastern, coffin, or hock joint, maybe. I had to look those up on Wikipedia. He's basically researched everything. He's collaborated with the who's who of orthopedics. We were just talking. There's not a person that you don't know that he doesn't know, including our own doctors Mattson and David Ayer, as well as, actually, he was telling me that Trey Green, who was formerly with us, and Kevin Smith, who's one of our colleagues at Northwest Hospital, also when they were residents, spent time in his lab in Michigan. Along with some of my mentors like Russ Warren, John Fowler, John Bergfeld at Cleveland Clinic, who was a mentor for Mia Hagen, and Joe Torg at Penn, Van Mao. The list goes on, and I was going through his CV, and I had something like 180 pages of CV to go through to try to get you a summary of what he's accomplished. So, and I think right now he's kind of putting all of his efforts into orthobiologics and regenerative therapies, and I think that's very apropos considering that these treatments have definitely been in the limelight as of recently. And kind of the last thing I wanted to do before I bring him up, and I'm sorry I'm taking so much time, but I think that all of us who have studied in orthopedics, and residents especially who are training and taking the in-training exam and getting ready for boards and things like that, have seen this top figure before. This is a very famous histologic section from one of Dr. Arnoczky's O'Donoghue award-winning papers back in 1982 that he did with Dr. Warren, who was a mentor of mine at HSS. And this is a cross-section of a human meniscus, and you can see kind of at the periphery there's a vascular plexus, and it doesn't invade the entirety of the meniscus. And so from that, this figure is not from that paper, but Dr. Arnoczky gave us this classification where he talked about the red-red zone, the red-white zone, and the white-white zone. And that really, we use this even to this day all the time when we talk about which meniscus tears we think we can repair in the operating room and which ones we would probably rather debride. So it's interesting, when I first read about this paper and saw it in like my review books in residency, I had to go and look up the original paper. And it's quite a number of years old, so you had to scan it. They didn't have it electronically, and I kind of scanned it crooked. But it was interesting. Later on, after finishing my residency, I got to train with Russ Warren, and he told me about Steve Arnoczky. And so I haven't had the pleasure of meeting him till today, but it's this kind of research where we had stuff that happened in the lab that directly translated into the operating room or clinic that we could affect patients with, that is so exciting for me. Has brought me to the career path that I've chosen. And so it's really exciting for me to get to meet Dr. Arnoczky, and please help me welcome him up to the stage here to give us his talk.
All right, here we go. Great. Well, thank you so much, Dr. Gee, for that introduction, and thanks so much for having me. It's great to see some old friends again, hopefully make some new ones. I'm a basic scientist by training, actually a veterinarian by training that went into basic science, but what I'd like to do this morning is, for the next 45 minutes or so, is talk to you a little bit from a basic science point of view, take a look at something that you deal with as orthodox each and every day, and that's the idea of tendinopathy. What I'd like to do is go over some of the basic science rationale for the current treatment algorithms and do that in the focus or the prism of the fact that why nothing works all the time. And you do have a lot of different things that you can do. And if there was one treatment or one regime that would work all the time, well, that would be fine and we wouldn't have an issue with tendinopathy. But we're going to kind of try to go through and understand why there's this big dichotomy of aspects of treatment of tendinopathy and why nothing works all the time. These are my disclosures. So tendinopathy is a major medical problem, as we talked about, associated with sports. Even people who are not sporting, like myself, still gets tendinopathy, just physical activity. I think the problem comes in, it's a generic descriptor of a clinical condition that it's usually associated with overuse. But that generic descriptor probably is a misnomer because it's such a long continuum of events that we talk about in tendinopathy, and that those areas of tendinopathy are different histologically as we progress through that. So it's not a singular disease, it's a continuum, and that probably is the underlying cause of why nothing works all the time. If you look at the different presentations of tendinopathy, both histological imaging and on gross exam, it's variable. It's highly variable, and the pathology is highly variable. And that is the underlying, I think, premise we have to understand, is that's why some of these therapies don't work all the time, because the continuum of pathology that's there is quite different at various stages. Now, the clinical syndrome you're all aware of. You have tendon pain, localized tenderness and swelling, decreased exercise tolerance, ends up to impaired functions, and it's often aggravated by continued physical activity. So that's what your patients come in telling you, and this is what you as a physician and a trainer and physical therapist see when you're looking at those individuals, whether it's on the elbow, the shoulder, the knee, or other areas of the body. And you have a lot of different treatment options available to you. So which ones should we be looking at? What is the basic science rationale for some of the currently advocated treatment algorithms for tendinopathy? And how effective are these treatments? I think it can be summed up quite easily.
They've done studies, 60% of the time it works every time.
So 60% of the time, it works every time. And that's the problem. If you think about it, it's probably 60% of the time, most of these things work every time. It's just picking out which of those times that we want to work. And so now it's important to understand when we talk about tendinopathy, it's not defined by the initial injury to a tendon caused by overuse per se. That's not what's happening. It's rather the clinical manifestation of tendinopathy is basically the inability of the tissue to sustain an orderly and effective healing response. So it's an abnormal response to the injury that the body has undergone. And there's a kind of a simple algorithm that Joanne Archambault talked about many, many years ago. You have repetitive loading of a tendon. You have a cell matrix response. This is a living tissue. So every time you load a tissue, whether it's a bone or a tendon, you have Wolff's law. Wolff's law of connective tissue is the idea that the body will respond to changes in load. And you'll see this not only in bone, but all connective tissues. And that response can be adequate or it can be inadequate. If it's adequate, then you have adaptation. Not everybody who exercises gets tendinopathy. They're able to adapt to those loadings. So if you're an athlete, if you do repetitive things, most of the time that you're going to be fine. If there's something abnormal, then you have an inadequate response, which leads to a series of pathological events that causes a transient weakness in the tendon. You keep pushing forward, whether you're working or whether you're exercising, trying to run through it, no pain, no gain type of stuff, and you end up having the overuse injury. So it's this bottom when the people come in, when your patients come in and actually talk to you about that injury, because now they're manifesting clinical signs that they've gone through all this kind of response one way or the other, and that's what you have to deal with. So we're going to focus on the inadequate response for that. And that inadequate response basically is a failure of the cell matrix adaptation to trauma due to imbalance between matrix degeneration and synthesis. So you have a negative balance. We're not keeping that homeostatic mechanism going. We have more catabolism than we have anabolism. And that's the idea we'll talk about where those products come up that start to degrade the tendon. Cater talked about a non-inflammatory introtendinous collagen degeneration with fiber disorientation, thinning, hypercellularity, scattered vascular ingrowth. It's the histological picture that Cater was talking about. Ledbetter was talking more generically about why we don't have that repair phenomenon. So there's many factors that may adversely affect the response to tendon to overuse. There's genetics. if you have a genetic imbalance. There are people who are genetically predisposed to factors that are predisposed to tendon injury, tendinopathy, because of differences in different biological factors. Gender. Females demonstrate different neurogenic inflammatory responses. Hart talked about this back in 1998, that they may be more prone to that inflammatory response. Age. As we get older, we see tenocyte and collagen degeneration. Our tissues do age. We get a little bit stiffer in those connective tissues, and they may not be able to respond, and that response may be more towards the inadequate aspect as opposed to the adaptational aspect of it. So that's an issue there. The biomechanics in terms of loading frequency and magnitude, and that's going to be important because on the top, this is Matt. Matt's one of our internal medicine people at the vet school. He's an ultramarathoner. And what you see on the left-hand side are just force distribution curves. You've got vertical force on the top, horizontal force on the bottom. You can see how narrow Matt is. It's about 3 times body weight. On the bottom, Tanya. Tanya is an anatomic physicist at Columbia, one of the engineers' wives that we work with. Look at Tanya. She's upwards of 13 times body weight under vertical forces. She's got that loping stride. She always has tendinopathy, always has knee and Achilles injuries. Matt really has any history of injury. So just by the amount of force and the extra tendinous types of things that people talk about in terms of conformation, and in this case, biomechanics, running style. Local and systemic factors, anatomic location, blood supply, cytokine production, there's all kind of things that can do. So there's a lot of factors that are involved with this. We did a study to look at the idea of why we get the infrapatellar tendinitis where we do. We found out using a finite element model that there is again, if you flex your knee in 60 degrees and you have a large contractile force on your quadriceps, you're going to hyper-load a certain area, increase tendon right at that location where we see the MRI expression of that. So there are relative changes in the local environment there, geometric environment, the strain environment that can predispose to this. So again, there are factors. The same thing can happen in the area of the shoulder and the Achilles tendon. Anatomical locations. We know about the idea of perhaps a watershed area in the supraspinatus tendon in terms of blood supply, whether that's a cause or an effect of tendinopathy or ultimate rotator cuff rupture. We're not sure, but again, there are limiting factors. If this is injured in that particular area, there's not a lot of vascularity to bring in the reparative response, and so you're kind of behind the 8 ball with that. Likewise, the same thing we did with one of our residents for lateral epicondylitis, local limited vascular supply here in the area of lateral epicondylitis. Finally, tendons have an inherently slow metabolic rate and a limited cell population. So they don't have all the players there like you would have in a bone that are very, very active. So they're fairly dormant and they have a very, very slow turnover. And indeed, most of the repair for tendons come from the peritoneum. So things like the Achilles tendon, you know those repair very, very nicely. You take out the central third of the patellar tendon for an ACL graft. That's going to regenerate very, very nicely, because these are peritoneum-covered tissues. And the peritoneum, again, is a source of reparative cells. Some people feel that they're mesenchymal stem cells, but they're also a great source of reparative cells. So again, it's the extent of injury dictates the level of response. And so when you have a fairly robust injury, like this, a surgical injury or a traumatic rupture, then that response is going to happen, and that tendon will likely heal itself. And those things come from the extracellular aspect of it. There's a great lot of histology has been done on the idea of what happens once you cut a tendon or a ligament and how it goes through and heals it. And so when that trauma is there, that's very, very important. The problem with tendinopathy is we never have that rapid or that raging type of injury. It's rather more occult. So what you're going to see here, this is a rat tail tendon. We're looking at it with a confocal laser microscope. We're just looking at the surface right now. And so what we're going to do is I'm going to start to load it. And we're using a stepper motor, so it's going to be a little bit herky-jerky. But watch what happens, and I want you to keep an eye on the lower aspect of that tendon as we start to load it. So we're going to start to load it, and the first thing, the crimp comes out, or the wrinkle comes out. We're pulling it, we're pulling it, we're pulling it. Now we're magnifying this quite a bit. This is like 3 times the thickness of a human hair. Watch that inferior margin. As we start to pull it, all of a sudden we're going to get an injury right there. You can see it. We're going to stop pulling, and what happens is we're going to keep the whole tendon taut, but where we injured it, it wrinkles back up because we just took a couple of those fibers and we damaged them. And again, this is 3 times the thickness of a human hair that you're looking at. So that's a rather small occult injury. You think, well, how much can that be problematic? It's problematic because if we look at in situ imaging of this, we can see that we have an immediate upregulation of collagenase. So when those tissues are not loaded, those cells are not loaded on that tendon, the tendon tends to go into a catabolic state. So right away, even with that micro injury, we have that increase of collagenase, but it's not enough really to cause an inflammatory response to go in there and start the healing response. So we have that imbalance of catabolism and anabolism. So the idea is that for the longest time, people said, well, you know, is it inflammatory, is it non-inflammatory? There's really a lack of a demonstrable inflammatory response historically in tendinopathic tissues. And this was basically, people said, well, if it's not inflammatory, why are you giving people NSAIDs? We know NSAIDs seem to work in some instances. Well, the problem is that most of those biopsies back in the 1900s and the early 2000s were done on pathologic cases where you were pretty far down on the disease, and they would say, well, you know, we don't see any evidence of what's happening in that particular area. So people have done a nice histological progression of the tendinopathic progression over the course of time. And if you look at it, it's a mixed bag. You can look at it and find anything. Histological presentation, as I said, can be quite variable. It can be mucoid degeneration, hyaline degeneration, fibrinoid necrosis, fatty degeneration, fibrocartilaginous metaplasia, where you start to see these cells get away from that spindle shape and turn into a more fibrochondrocytic type of cell, which is less responsive to any of things like PRP or any kind of stimulant that may be there to increase cellular activity. So that's problematic. Neovascularization and cellular and tenocyte infiltration can occur. Angiofibroplasia, people talked about, Nerschel talked about that. That's really the idea where the body's going crazy. It's throwing a bunch of vascularity in there to try to repair it, but it's so hither and yon that you end up having more pain because you have the nocifibers of pain receptors that come in with those vascularities, and we'll talk about that in the treatment. So depending on the stage of the disease, it's highly probable that the histologic exam may reveal a heterogeneous pathology even within an individual tendon. So you have the whole gamut here. So again, you can understand how complex this is. This whole terminology of tendinopathy is far more complex if you just look at the histopathology and what is happening. Recent basic science studies have identified also that early on there are inflammatory cells as well as pro-inflammatory mediators. They're not the classic inflammatory cells of white blood cells and lymphocytes, but rather there's a release of inflammatory cytokines by tenocytes. Tenocytes who are not under load, those things we talked about before where we saw the increase in collagenase, they will also increase pro-inflammatory cytokines. And those pro-inflammatory cytokines are what causes what people call the chemical irritation of inflammation, or the chemical inflammation that does produce pain. These mediators will also be related to the pain production. So even though we don't have the classic inflammatory response that we would see, there are inflammatory mediators, and this is probably why early on the NSAIDs seem to work quite nicely. Because the pathology of tendinopathy can differ at various stages, the therapeutic interventions, and here's what we talk about the whole topic of the lecture, should be tailored to the predominant pathological process. And here's where you need to come in now. How do you define and how do you find and pinpoint what that pathologic process can be? And that's kind of hard because applying a single intervention in all presentations is unlikely to be efficacious in every case. You can kind of see it. Look at the patellar tendon here. This is the whole kind of progression where you get a little bit of patellar tendonitis, then you get more, then you get the entire tendon involved, then you finally get the rupture. So you can see you can intercede here at any position or any point in this whole pathology, depending on when your patient comes in. And again, the treatment is going to be a lot different at these various locations. You read the literature and you see that people have some consistent outcomes with therapy. These are probably due to the fact that the patients are clearly in a specific pathological group. So they are in an early group or a late group or medium group, whatever, from a timing point of view or the pathology point of view, that allows those outcomes to be more uniform and more predictable, if you will. And again, the variable response seen within and among studies may be explained in part by the existence of subpopulations. So don't just look at somebody and say, well, they used this particular therapy and only half the people got better, or 60% of the people, as was said before, got better. It's probably because there's a variation in the pathology that's there, and you're not treating the same thing in all that particular group. And it's going to be up to people in radiology, the imaging people. Talk with Hollis Potter a lot about are there better ways of imaging tendons to find out that we can look a little bit closer, if you will, to find out what that pathology is. So what you need to do with all that kind of as a background, there needs to be a unifying approach to predicate the therapeutic approach to tendinopathy. And this was put forward by our friends down under, Jill Cook and Purdom, in 2009. They talked about a natural history of tendinopathy represents, as we talked about, a continuum of events whose progression, and most important from your point of view and the patient's point of view, excuse me, potential reversibility, are dependent on the extended damage and the ability of the host tissues to respond to intrinsic or extrinsic stimuli. How much the body can do, how much you as a doc can add to that, either with your surgical expertise or the therapeutic expertise that we're going to bring forth. And so we have this continuum where we have the ability on the left-hand side for those tendons to repair themselves. And this probably happens more often than not because the patients never even come to your clinic. They may have some tendinopathy. They decide, well, I'm going to put my foot up for a rest. I'm not going to run the next week, or I'm going to back off playing golf after a whole winter of not doing it. And all of a sudden, my tendons start to feel a little bit better. Then you get into that bigger area here, the yellow area. This is where you see the clinical manifestations where people are coming in because there's a failed repair. Mother Nature and the patient can't do it. And then you get to the right where there's red, where you get degenerative and rupture. And these areas are very, very difficult. In that yellow area is where we're going to focus, and that's where the treatments may be able to reverse or correct that failed repair and move it towards the left. And that's how we're going to use, or how we're going to focus these treatment regimes. So repair, again, that's the adequate response. And so what happens is you may have some minor injury, but again, if your patients are available or able to take on their own rest and therapies that that they know better, the body will go ahead and repair itself. And these here we call reactive tendinopathies, and this is characterized by the initial non-inflammatory, a classic non-inflammatory response, but you do have those inflammatory mediators, proliferative response as a result of altered cell matrix interactions. And what you have here is a histological picture from Ed DiCarlo from the Hospital for Special Surgery. The biopsy here shows cell metaplasia, cell proliferation, some separation of the collagen fibers, and a local upregulation of inflammatory mediators. So it's in that area between repair and failed repair. It could go either way. But right now, the body still has the ability to turn this around and allow this to go ahead and heal on its own. Mother Nature can take care of that. Isolated fiber damage following tendon overload, as we talked about, can have an upregulation of pro-inflammatory mediators. This is a picture of a histological picture of a tendon, and it's not put together by Photoshop. This actually shows the inner connection between the injured and the uninjured portion. And so it's the junction there. And if we go ahead and stain this with an immunohistochemical stain, it's hard to see here, but on the injured portion, that bright red and orange is all collagenase being upregulated right next to a normal tendon. So again, you can see those localized inflammatory mediators there. And if we can do something to quiet those things down, we should be in good shape. The tendon disrepair now, so we've got that position here where you've gone to repair. Now we're coming into that yellow area here. Now we're starting to see things that maybe not allow Mother Nature to heal as well. The cells become more chondroid. When they become more chondroid, they're less metabolically active, less able to respond to growth factors and paracrine and autocrine stimuli. There's neoangiogenesis and nociceptor proliferation. So Mother Nature is trying to do something. This is that angioblastic fibroplasia. She's trying to do her best, but when she's doing this, it's kind of disorganized. It's almost like the idea that this individual may still be exercising, still may be working on that particular tissue and straining it, and we have that breakdown. We have that increase in catabolism, that loss of balance between anabolism and catabolism, and now we start to go down that slippery slope. We're starting to get collagen degeneration. And once we start doing that, then we start to weaken. It's a cyclic event. It's almost like cartilage breakdown. All these things, if you think about the disease process in musculoskeletal tissues, whether it's osteochondral or osteoarthritis, or in this case, tendinopathy, it's not that much different. You start down that slippery cycle, and it continues on and on and on. You have this idea that you have the angioblastic fibroplasia This is where the patients get the pain. They come in and say, "Doc, I can put my finger there. Gosh, it hurts like heck." It's because these nociceptive fibers are coming in, and there's a disorganized repair, but those nociceptive fibers are picking up substance P and causing a great deal of problems. And so that we have the presence of these neuropeptides we talk about and substance P that are there. So it's, all those things are happening that cause that pain to occur in this area of disrepair. What's important to remember is that tendons appearing normal on imaging can be painful. So again, this is the variation in pathology. You can have someone that you do an MRI on that looks perfectly normal, but this patient has pain, and that pain is because they can't pick it up on ultrasound or can't pick it up on changes on MRI. And again, 2/3 of tendon degenerated enough to rupture have been reported to be pain-free prior to rupture. So you can start to see the issue here where there's no clear clinical picture that really delineates and can be associated with what's happening pathologically. Pain, we know with angiofibroplasia, but again, pain is not always a reflective of the extent of damage. And then we start to get towards that point of no return where we have hypocellularity, so we don't have enough players there to do anything even if they could. We have increased programmed cell death, and we have matrix degeneration. So now we're looking at a tissue here that's pretty nasty, pretty fibrous, and again, really lacks any reparative type of phenomenon here. So the therapy as we get down to here is going to be needing to be a lot different. So let's take a look then at that continuum. And we can basically put it in from a therapeutic point of view, two big categories. One is going to be reactive or early tendon disrepair, and the other is going to be far on the right here, late tendon disrepair or degeneration. So if you think about your patients this way, instead of trying to get them all into those many categories, we try to break these down into two very general categories, early reactive and late tendon disrepair and degeneration. The reactive tendinopathy, again, is pretty simple. This is something that you know better than I. Just eliminate precipitating factors. This is load management. Reduce the intensity and frequency of loading. Minimize inflammatory mediators in pain. So it hurts when I do this, doc. Well, don't do that anymore. So that's the eliminating the precipitating factors. The late tendon disrepair is going to be a bit more. You still want load management, but now you're going to have to do something to really kickstart Mother Nature. Stimulate cell activity and extracellular matrix production. Inhibit that catabolic enzyme production, get it back to at least a homeostatic, if not an anabolic balance. And then you want pain relief because some of the therapies are going to require that the patients do some exercises. And if they can't do those exercises because of pain, it's not going to be very, very good. So here, again, kind of in generically, reactive tendinopathy, you want to optimize the healing environment. You want to be able to take that yellow and push it towards the left to help Mother Nature get through that repair. And Hippocrates said healing is a matter of time, but it's sometimes a matter of opportunity. And the opportunity is best at this early stage if you can connect with it, because Mother Nature still has the ability to help you, and you have the ability to help Mother Nature. So together in this partnership, you can move forward with Mother Nature probably doing more of the work. You get to late tendon repair, now you need to stimulate or kickstart the healing process. And this is again from Girdlestone. Healing cannot be imposed, but may have to be encouraged. You're going to have to do something there to really push Mother Nature to get to that situation. So let's start looking at those different therapies. You want to eliminate precipitating factors by simply reducing the intensity and frequency of loading. Remember that tenocytes are mechanosensitive cells which respond to alterations in frequency and magnitude. So they need exercise. They're just not dormant. It's not a tissue that is just a non-viable. It's a viable tissue. It reacts to Wolff's Law. And so it does need some exercise and stuff. So by exercise, we need to do that. The use it or lose it phenomenon. Well, we want to stay in that balance area here where we're trying to balance the catabolic and anabolic stimulus. So your physical therapists are going to be important. It's just not immobilizing individuals. It's allowing them to have more controlled movement. And the orthotics here is where you kind of come in. You increase localized tendon strain at the site of injury, as we talked about with that infrapatellar, may be what's happening in disrupting that repair. It's almost like motion at a fracture that causes a delayed or maybe a non-union. So there's a lot of different orthotics out there. And the proposed mechanism of action is to remove precipitating factors and prevent re-injury by decreasing local strain. Now, you look through the literature, and there's not a lot of literature about how in the world it decreases the local strain. So our lab, this is all in theory, our lab did a study where we went and took our finite element model, And we did the infrapatellar bands. We put it on a group of volunteers in an IRB-approved study. And then we did the anthropomorphic measurements of the patellar length and put that into our computer model and showed that when you have no band, we have that increase in load there, that strain that we talked about at the location of the infrapatellar tendinopathy. But when we did the band, that decreased significantly. And it was because we changed slightly that patellar tendon angle. And also by putting a little crimp into, if you will, that patellar tendon, we actually shortened it. And that changes and that decreases the strain placed on it. Patellar bands, again, may reduce tendon strains by increasing patellar angle and decreasing the patellar tibial distance by basically lessening the applied tension strain. So there's a mechanism, there's a really valid mechanism for why these things go on and work. People looked at the forearm bands. There's a couple articles talking about forearm bands for lateral epicondylitis and others. Forearm support, again, basically some people think it prevents the muscles from contracting too much by preventing the expansion of this by cranking down on it. The force reduction of the forearm support is proportional to the pressure of application. It's important to understand with any of these orthotics, and we found out this with our infrapatellar bands, if you don't put them on correctly, they're not going to help you at all. And any of us who played pickup basketball, there's always 2 or 3 guys that have the bands or an ACE bandage wrapped around them because it feels better. We had a physician, orthopedic surgeon Julie Dodds, apply the band each and every time because if we let the patients do it or the volunteers, they did it different ways and it really didn't have its effect. So it's important that you, if we're going to use these devices, understand how they work and make sure your patient understands how important it is to put these on correctly. Minimize the inflammatory mediators of pain. Again, we talked about the sources of pain are the stretch receptors. There are stretch receptors, so if you're increasing the strain, you may be problematic there. The cells die. The cells die and they release noxious stimuli. There's matrix breakdown products that are going to be toxic, so there's a chemical a source of this particular pain. We said high concentration of substance P and neurotransmitters. And again, the idea of pro-inflammatory mediators simply produced by these cells, either over mechanically stimulated or under mechanically stimulated. So again, you have those sources of pain. So there are good things to do. Cryotherapy, again, you slow down the metabolic aspect of it. So again, when different things, when you have a baseball pitcher and after a game, they're going to go ahead and slow down the metabolic aspects of those particular tissues. We know that following different surgical procedures, cold is a good diminution of pain. NSAIDs, again, they basically interfere with the production of the allogenic metabolites, which are the pain metabolites, and they decrease, of course, importantly enough, they decrease cell proliferation, extracellular matrix synthesis. So there's a balance there. You don't want to go crazy with that, but you want to make sure, again, that this opportunity allows for relief of pain with the NSAIDs. And corticosteroid injections, the peritinus, you don't want to put it into a tendon if you can help it because you're basically there to decrease the inflammatory aspect of decreased neovascularization, decreased cell proliferation is a side effect which is not always beneficial, and it does have a deleterious, these repetitive injections on tendon healing and tendon mechanical properties. So again, it's things that you do. It's logical. These are things that are inherent and they're very, very logical for that early optimizing the healing environment in the healing or the repair or early stages of disrepair. It becomes more problematic now, and this is where that 60% of the time it works every time, where you get to the late tendon disrepair and you have degenerative tendinopathy. And now you need therapies which are intended to really kickstart the process, intended to do this by either increasing blood flow, stimulating cell activity in an effort to enhance or reinitiate the healing response. Mother Nature tried, she didn't do it very well. You need to go in there and see if you can help. So it's Hippocrates' classic, changing a chronic response to an acute response. And there are many, many ways to do this, both surgical and chemical. So there's heat treatments, radiofrequency. We'll go over these all briefly, but these are the ones that you have available to you and that have been used to varying degrees of success based on the extent of pathology. Thermal energy is probably the oldest. If you get a textbook from the 1600s, a surgical textbook, one of the quotes is, "Wounds that are not curable by iron," which are the surgical instrumentations of the day were made of iron, are curable by fire. And if you go back into those texts, you can see people use cautery a lot. This looks like a fondue pot, but it's actually a different, has hot coals in there. There are different types of instrumentations there. It looks pretty nasty, but this is what was done for anything and everything that was treated with that, taking something that was chronic and making it acute. In veterinary medicine, we did similar things early on in the careers of veterinary medicine. We don't do these anymore. But bowed tendon, you can see how that tendon and the posterior aspect of that superficial digital flexor tendon of this horse is kind of bowed out, and this is where it comes. And this is one of the more common injuries, thoroughbred race horses, and not so much in pleasure horses, but really the performance horses. And what we used to do is take a chronic situation and make it acute by firing it. We would take things that look like Steinman pins. This was already outlawed by the time I was in vet school, but they would put it into really heat it up and actually into a fire sometimes, and then under local anesthesia, they would stick in these probes, and you'd get this huge inflammatory response, which would then take this chronic situation, make it acute, and hopefully drive it more towards that reparative. It was rather barbaric because, again, sometimes the block was not that good, the horse was in pain. And we learned very early on that heating soft tissues can be dangerous to veterinarians. Watch how fast this guy leaves the screen. This is amazing to me. So the next time you're using a radiofrequency probe on your patient, keep that in mind, that picture in mind. So what do you have available to you? Well, you do have radiofrequency. This is a thermal stimulus of healing, and basically you're trying to increase blood flow, a stimulation of cell activity, and they've also shown that it can deactivate nociceptor fibers. And there are different radiofrequency wands that you can do this now transdermally. Again, ultrasound, either pulsed or continuous, this is the same type of thing. It's a thermal stimulus. You do increase the local temperature there, which again causes vasodilatation, increased blood flow, and again, stimulation of cell activity. Remember, you're just trying to take what Mother Nature has and trying to reorganize it and get her back on track a little bit. Ultrasound injury, this is from Bernie Morey and the 10X group. Basically, it's an interesting concept here with basically you have the high intensity radiofrequency that basically is based on a resonance that basically will take care of diseased tissue and not damage a normal tissue based on the water content. So basically you go there and you basically fragment, emulsify, if you will, the pathologic tissue, and then it gets sucked out. And so this can be done transdermally under local, and this has been a therapy that, again, is not caught on completely, but more and more people are looking at it. And I think once we get more papers out, people talk about it more, we'll have a better idea of what its capabilities and limitations, but kind of an interesting technology that's coming out there. Low-level laser energy, this is not really thermal energy. It's a different type of energy, as you well know. People have known or shown that, again, it increases the anabolism with increased collagen synthesis, increase in angiogenesis. You may want to say, well, why do we want to have angiogenesis or inflammation? By the time we get to this part in that yellow area there, we're not having that that response, that inflammatory response that is ordered. It's disordered. We want to get back and get it in a more ordered way. Sometimes we have to go back to the beginning and start things all over again. Electrical stimulation has been around since 1850, and oftentimes for bone. Again, it's a pain inhibition. It causes increased cell migration and proliferation, increased protein synthesis, increased angiogenesis. So again, electrical stimulation has been used in a lot of connective tissues to varying degrees of success. Shockwave therapy has been big for some individuals for tendinopathy. It induces microtrauma. So it's the same way you're inducing microtrauma, but you're doing it transdermally, which again stimulates a healing response. You actually fracture or damage the capillaries, and which again turns around and stimulates angiogenesis. It also is thought to decrease substance P and destabilize sensory fibers. Something about the resonance of the shock waves is thought to destroy those and diminish pain. It also stimulates growth factor production, and I'm not exactly sure, but they claim it inhibits MMP expression. I'm not exactly sure how it does that, and there's really no explanation for that. But again, this has been very, 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 very popular in certain areas for tendinopathy that I've talked to some physiatrists. PRP, big thing now. It's kind of waning a little bit, but people are still using it. Remember, platelets contain over 1,100 bioactive growth factors. There are MMP inhibitors. They're also inflammatory cytokines. So you may just be putting in an irritant that is almost like prolotherapy, which we'll talk about here in a second. But basically, you're taking that chronic condition, trying to make it acute with the irritant. But here, if you're thinking about it, if the cells are able to respond to those growth factors, they will. If it's too far to the right, remember we saw all those cells that are fibrocartilaginous and undergoing fibrocartilaginous metaplasia? Those will not respond to PRP. So you can inject that till the cows come home and nothing is going to happen with those patients because the cells aren't there. You're going to have to do something else, which we'll talk about here in a second. Autologous blood. Dr. Nerschel talked about this, advocated this many years ago for lateral epicondylitis. Basically, the heme in the iron in the red blood cells are irritants. And you will, if you inject this in here at the time, again, they contain the same factors as PRP, the whole blood, but in much lesser concentrations. And I guess the heme is oftentimes a potential irritant. And we can't discount the idea of just sticking the needle in there. Nerschel also advocated the traumatic disruption by dry needling. This was a very favorite therapy for lateral epicondylitis for many years, still is for certain indications for that. And basically, you're trying to take this chronic situation and make it acute by making local therapy. So instead of doing it with ultrasound or shockwave therapy, you're actually physically going in and disrupting some of those areas that are important. Prolotherapy is really coming back. It was very popular in the 50s, and there's textbooks actually talking about the injection of sugar water, if you will. It's just it's hyperosmotic dextrose that you put in this case, 50%. And basically, you crenate the cells. You change the environment, the osmotic environment. The cells lyse. They release inflammatory and degradative products, and you start a whole inflammatory response that basically is there to cause proliferation and fibrosis. It's not a very organized response, especially in the area of tendons. There are better things we can do, but still, people now there's kind of been a resurgence of prolotherapy in certain geographic areas at least. Eccentric training. This is and it makes it kind of difficult to understand when we talk to some of the residents and some of the students about this. He said, well, Steve, you just got done saying it's due to overuse. Why in the world would you want to train and do these eccentric loading? Well, we said that it does stimulate a mechanobiological induction of anabolism because what happens is that you really need to get those cells in that homeostatic way. Eccentric loading may increase the resting length of the tendon, thereby effectively reducing the strain. So maybe this is a way of load modification. And increased tendon cell strain provided by eccentric loading may also be beneficial in inhibiting MMP production. Remember we said the inflammatory cytokines in collagenase, which is an MMP, upregulate when that part of that tendon was damaged. So what we decided to do in the lab is see if we can replicate this importance of balancing anabolic and catabolic stimulus. It's hard to see here. So we took that rat tail tendon and we basically put it in a petri dish and just not loaded it, just let it lay there. So it's like unloaded. After one day, we start to see an upregulation of MMP. This is the yellow under immunohistochemical stain. This is a live cell stain, so we're actually looking at it with a confocal laser microscope. We're looking inside it. And we can start to see these cells be problematic here in terms of upregulation of that by having stress deprivation. So what happens is we exercise them. We have a little machine that we can put in a lab and put it in an incubator, and we exercise. We can make them run. We can make them do sprints. We can make them do marathons. And basically, substance P production induced by 24 or 48 hours of stress deprivation is increased. So we actually looked at substance P as well as the immunohistochemical stains for MMPs, but substance P was this one. And what we saw here is that after 48 hours, it's hard for you to see here, but we see upregulation of substance P. If we did 24 hours of stress deprivation, 24 hours of exercise, we could completely inhibit that. And so exercise is important. It's not just total rest. You have to have some controlled exercise for that. Same thing, 72 hours of stress deprivation, 48 hours of stress deprivation with just 24 hours of exercise, we were able to reverse that. So exercise is important. We think this is why maybe that eccentric loading is going to be important when we get to those inhibitions of those enzymes and the substance P. Also, things as simple as frictional massage, deep frictional massage. You get in there and you're breaking down the adhesions, you're breaking down connective tissue areas and increasing the blood flow. And again, you stimulate the mechanoreceptors. So it's almost like the exercise, but basically what you're doing is doing it on a far more local level and breaking down and kind of, again, stimulating that healing response over the course of time. There's nitric oxide patches that people have used with varying degrees of success, and it's basically there to, again, enhance blood flow, and it's thought that the enhancement of blood flow will lead to enhancement of the extracellular matrix synthesis. We talked about neoangiogenesis being good, but if it can be too bad, it was that neoangiogenesis, as we talked about, or angiogenic fibroplasia, is bad, and the colleagues in Scandinavia came up in the mid-2000s. Basically, they injected polydocanol to basically thrombose the vessels, same thing you would inject into people with varicose veins. The sclerotherapy, and the idea was by doing that, you would basically remove the pain, and here it is pre-op and then post-injection where you thrombose that, then allow the individuals to go on and do relatively aggressive eccentric loading. It was the Scandinavians that brought us eccentric loading, and the benefits that Alfredson and Olberg and others have taught us really are beneficial over the course of time. So being able to really eliminate that pain and allow people to have that exercise was beneficial. High volume injections. Basically what you're doing is the incompressibility of water in a confined space, so they would inject large volumes, 50 milliliters of saline, with a local analgesic and oftentimes a steroid to mechanically disrupt those vessels. So basically in a confined area like a tendon, you can go ahead and thrombose by just doing these long, high injections. And Mafuli from the UK and others have published extensively on this with, again, varying degrees of results, but it seems to be a potentially beneficial area. MMP inhibitors we thought was going to be real big, but remember the MMP inhibitors that we have now are generic. They're large. In other words, they inhibit the different 4 classes of the MMPs. And MMPs are not necessarily always bad. They are good. They do some good in things we do. So by inhibiting the MMPs, we not only maybe change some of these pro-inflammatory aspects of it, but we can do some damage. And these have never really caught on completely. There are some new ones coming up that are more boutique, where they're really focused on a specific MMP that might, in fact, be beneficial in the future for tendinopathy. Finally, again, we get to the point of now we get to the far end of the disease. What's going to happen? We need to do something to add cells because the cells that are there are really not metabolically active. And so now people talked about mesenchymal stem cells and the idea to replace lost or senescent cells in degenerative tendinopathy. And we know now that they're really not there to turn it back into a tendon, but basically they're there as trophic agents, providing both an autocrine and paracrine stimulus through the production of growth factors. Now, the idea is that if they're there for long periods of time and can produce these growth factors, there's going to be a mitogenic and chemotactic response, so other cells from the paracellular or the peritoneous location can come in and cause the repair. But we need them to be there for a longer period of time than just injecting PRP or some limited growth factor. And so the trophic aspect of it, as Arnie Kaplan from Case Western Reserve has taught us, is very, very important now with mesenchymal stem cells and the extracellular vesicles that these mesenchymal stem cells produce. So they do provide the synthetic machinery for the generation of these extracellular matrix components. In veterinary medicine, here's one we had. You can see the lesion. The lesion in the superficial digital flexor tendon is that core type of lesion. And so this work was done at Cornell by a colleague in injecting bone marrow aspirate and injecting into it, and over the course of time was able to, again, regenerate or heal that tendon with a dense regularly oriented connective tissue, which is reminiscent of a normal tendinous type of tissue. Now you can have marrow-derived stem cells or adipose-derived stem cells. The problem is we don't know how much, what's efficacious, what is the dose response for this. So there's a lot of work being done, but none of it really has led us to a paradigm that we can say clinically, saying, all right, you need 3 million cells for this or 2 million cells for that. So kind of the jury's still out on this. It holds great promise, but we still need to have more information before we can really identify which of this is going to be the best and what is the appropriate dosing of this. And finally, a new technology that's coming out. It's really an old technology, but new for connective tissue, and that's amniotic derived stem cells and amniotic derived membranes. Remember from your OBGYN days in medical school, you've got the amniotic sac and then the amniotic fluid, which cushions the fetus during development, but also adds to the development of the fetus and protects the fetus not only mechanically, but also biologically. And the idea is they have all these different growth factors in the membrane and the fluid. There's a great article that says it's not just fetal urine anymore. People used to think about this as being waste products, but it has all these wonderful factors here that basically the vast majority of them are regenerative factors, and if we can put them into a little bit easier bioactive characteristics, they are anti-fibrotic and anti-inflammatory. So the idea is that this may be, and people are starting to do clinical studies injecting these into tendons now to look at the anti-fibrotic, anti-inflammatory aspect of it to reduce pain and inflammation, inhibit scarring, because one of the problems is that if we have an abnormal healing in the tendon, we get scar tissue, and that scar tissue is not going to last forever, and we're going to get more injuries down the line. So if you can diminish that amount of scar tissue with this, it may be beneficial. And again, we know it's immunologically privileged, and it is shown to enhance wound healing. And historically, they've used the membrane to, again, to heal corneal ulcers. We don't want fibrous tissue there. We don't want anything opacification. So there's over a 100-year history of using amniotic-derived cells, amniotic-derived membranes, amniotic-derived biologics in the area of regenerative medicine. So it's pretty interesting. So hopefully we've given you kind of an overview of what's out there. You know what's out there better than I probably. But the idea is that there's a method to the madness, and when these should be used, at least from a basic science point of view, and hopefully from a clinical point of view. Remember that no single treatment can unequivocally be identified as the most important treatment. You don't want to have one arrow in your quill. You want to have a lot of different therapies that you can use, and over the course of time, you'll find out which one seems to work well with what type of pathology. And again, remember the variable responses seen in the studies may be the fact that, again, there are subpopulations. It's not the fact that this thing doesn't work or this treatment doesn't work all the time. There may be subpopulations there, and so the importance of identifying those. And when you have a more consistent pathology, you're likely to get more consistent outcomes, or at least a better testing of the treatment that you're looking at. So hopefully we've given you, again, early in the morning here, but a basic science rationale for current treatment algorithms and a better understanding of why these therapies, why nothing works all of the time. So thanks again for having me. It's been my honor to be here. I appreciate it very much. Thank you. Is there any questions I can try to answer for you? Yes.
That was a wonderful talk. My question is, in these days of evidence-based medicine, you showed the variability among patients and the treatment modes, location, and strain. How can we standardize a protocol, which would be, based on large double-blind control studies of evidence?
I think the area here is that we talked about, and again, talking with people like Hollis Potter and others, is being able to do a better job of defining what the pathology is. Because only then you can really develop the inclusion-exclusion criteria to do exactly what you want, because otherwise there's going to be these subpopulations. So being able to identify that pathology specifically on imaging, then putting them in a subgroup, and then allowing that subgroup to look at a prospective randomized study. So it's big. Right now, a lot of this is anecdotal. Some people, if you talk to, I've been on ICLs at the Academy talking about tendinopathy, and some people swear by, all they use is one of the therapies here, whether it's going to be, ultrasound, pulsed ultrasound, or other aspects of it. It's what they focus on, what they believe in. But we need to have better diagnostics if we're going to develop those truly inclusion-exclusion criteria that allows us to do a well-designed prospective randomized level 1 study. Yeah, it's a tough one. Otherwise, we would have done it already.
It looks like we need dozens of those.
Oh,
right?
yeah, well, exactly.
Exactly.
I think what you can do, though, is if you can find out and kind of group the mode of action, as we talked about. Certain mode of actions are there to kickstart and identifying, saying if you get in that pathology that's right in the center of that yellow line, we're going to see what these treatments that have a similar mode of action. If we can look at one, chances are the others will hopefully follow in the same light. Okay? Thanks.
Thank you for that presentation. That was a wealth of information. In your studies, based on the pathology, you can see the difference between the tendon reaction, but is there, in terms of like how long it takes for someone to progress from that acute to that more chronic state?
No.
Any identification of that?
And that's the thing, talking with Ed DiCarlo, a lot of times the clinical signs do not reflect what the pathology is. And so there's not a way for you as a clinician to turn around and say, okay, if Mrs. Jones comes in there and if she's got pain over here or tenderness over here, the pathology is going to look like that. So it's going to be in that reactive or the non-healing, so I'm going to give this therapy. That's the issue that we were just talking about. It's just not as clear, and that's the problem. I mean, the pathology, even in one tendon, we can find one tendon that I remember that Dr. DiCarlo gave us that was a post-mortem tendon, and throughout it we could identify any one of those pathology pictures that we talked about: fibrinoid necrosis, chondroid metaplasia, fatty infiltration, angiogenic fibroplasia in one tendon. So it makes it very, very difficult. That's why it's a big problem. We don't have a final answer. Yeah.
Sorry, it's not related to your direct, but you were talking about treatments. I was just reading a JAMA article just within a couple of weeks. They are implying that we use statistical significance of 0.05. They said that will lead to wrong conclusion most of the time. So they are suggesting that the statistical should be at least 0.05, but better statistical methods to really compare two different treatment modes. Otherwise, you're going to get wrong results.
Well, but I think that depends on your outcome metrics. You know, the idea of it is clinical significance and statistical significance. You know, I have a slide that talks about this one drug. If patient had drug A, they were in the hospital for 3.2 days. If they had drug B, they statistically were in the hospital longer, 3.8 days. You know, they were both in the hospital for 3 nights. So statistical versus clinical is different. So the idea is minimal clinical significance is now people moving towards that, but it goes on to sensitivity of your outcome metrics. So your outcome metrics, whether it's the the different for like ACVS or constant scores for shoulder, which ones are validated and which ones can show you a 10% difference. If you're looking for a 10% difference, then you can go back and calculate out what your statistics should be. But that's a valid point. But I think we end up looking at, from a basic science point of view, we look at things that are statistically significant but may not be a whole heck of a lot of difference clinically. And we have to marry those two if we're going to advance the therapies.
Dr. Arnoczky, that was just fantastic.
Oh, thank
and as
you.
a person who has been involved in a One Health initiative at Texas A&M between the vet school and med school, that bringing of animal medicine and human medicine to understand both better is just profound. The question that I have is, when we operate, are we doing a Control-Alt-Delete on this process? In other words, we're taking something that's in this chronic state, and then we're disrupting it and resetting it, and the healing process is so much more powerful when you intervene surgically. Is that what's happening? Why, when we've injected it and it doesn't work, but then we open it and lift it off and repair it back down, then it works?
I think, yeah, we talked about the idea. There's a certain threshold of damage that really sets off the healing response. So when it's occult, like we see with tendinopathy, this is why you get the more chronic aspect of it. So you're absolutely right. The idea is taking a chronic condition, making it acute. In the old days, it was with fire. Now we can have surgical. You know, one of the biggest things was just making the incisions into the tendon. For the longest time, would do that. But now people want to do it peracute. They want to be able to do it in the office. So we get away from a lot of those other therapies. So when they get to the surgical aspect of it, it's pretty far down the line. And you have to understand about where that individual stands. If that individual is compromised in any way, whether it's from diabetics, has a smoking or other healing aspect of it, that whole philosophy has to change a little bit. But you're absolutely right. You're just doing a lot more trauma, and we can reset it. Like you say, the Control-Alt-Delete, we're going to go back to square one, which in some instances is good. In some instances, depending on the individual, again, just from a purely basic science point of view, I think we'd have to weigh that. I mean, I think if you had a younger, active individual that was healthy, I would try, if it was mine, I would want the least invasive one. If you get to the certain point where you're saying, listen, we've tried, it's just almost like, when do you go in on delayed union? To go ahead and heal before it goes to a non-union, you say, well, I'm going to give it a little bit more chance, Well, you got to go in there. It's really not any different than that. It's going in and making the decision and saying, okay, Mother Nature tried, she couldn't do it. Now it's up to you.
Yeah, the other thing is that recently the volume of, to optimize the mesenchymal cells from bone marrow aspirate, we did a study that showed that just for osteoblast count in children, you have to have a lower volume of aspirate. So if you get above 3 to 5 cc's, all you're drawing is blood, which might be okay. But if you keep just sucking on the marrow before you inject it, so these volumes of what optimizes in a child or an adult, it seems like we've got a lot of work to do in that domain also.
Absolutely. I'm always amazed when someone will tell me, I pulled out 40 cc's of bone marrow aspirate from my patient. I said, well, you probably did 5 cc's of bone marrow and 35 cc's of venous blood, and then you dilute it. So when you inject it, you've got something different. I mean, that's the thing. We want to standardize it. I know if you had a bottle of 2% lidocaine, you know exactly how much to inject into my elbow to get the effect that you need, that I need to release pain. We don't have that benefit right now with standardization, even with the PRP. PRP is all over the place, and it's not because PRP doesn't work. We may not be giving enough at the time until we do those controlled studies. And likewise with mesenchymal stem cells, we're not going to know. It has great promise, but we really need to get to the point where we can standardize it more. Given a standardized treatment, you guys will go crazy with it, and it'll work out quite nicely. But if it's not standardized, then we get discouraged because 60% of the time it works every time. Well, great. Thank you so much. Hope you have a great day. Thanks for having me.